This to say good morning to you, and I hope that everybody got a cup of coffee this morning, so you are not sleeping. And if you are sleeping, I'm going to wake you up. So this is the topic that I'm going to talk today. And as you see, it's dealing with the liver. And it's dealing with the liver malignancies. And it is something that we see every day in our practice. So I think it's important to know how you can proceed by imaging if you want to find the liver malignancies. Those are the learning objectives, and I'm not going to talk about those, but the most important thing is I'm going to show a little bit of pathology. It's important to know what kind of imaging modality you want to have in order to proceed to the diagnosis, and to learn about criteria for assessing tumor response. Because we as radiologists, we are not working for ourselves. We are working for the clinicians. So whatever we do, we need to persuade the clinicians that we are right. So what is the role of imaging? You see here a cirrhotic liver. So the very first important thing is before you proceed to the diagnosis of the focal liver lesion, to evaluate the underlying parenchyma. Is the liver parenchyma normal or abnormal? And it's very important, because the most common malignant lesion in a cirrhotic liver is not the metastasis, but the hepatocellular carcinoma. So after evaluating the underlying parenchyma, you proceed and you try to find the lesion and to characterize the lesion if it is malignant, to indicate management options. Is this lesion to be operated, or what is the potential treatment? And to hear and to know about those criteria of the solid liver lesions. So what we have for imaging modalities? We have the sonography. Some of radiologists, they use contrast-enhanced sonography. Not everybody. CT. What I'm going to show you, it's not a very sophisticated 128 CT machine, but they are real simple images from any CT you can get in the world. MRI with the potential of doing all in alone. I'm not going to talk now about PET-CT, but in the workshops, since PET-CT is not the primary method to detect liver malignancies, but it's used as whole body imaging to find additional malignancies, probably from the liver too. And ERCP, because we need to know what is our strength as radiologists as opposed to gastroenterologists. You're going to find in your syllabus literature reference, so you can find those. So the most important thing by sonography is not to be fooled by pseudo-lesions, such the one that is seen in segment 4. To evaluate if the lesion is solid or cystic, because this is important for the characterization. To see if there is dilatation of the bile ducts, because this is important for a potential liver malignancy. And to know that with sonography, we're not able always to find the final diagnosis. There are some advantages by color Doppler sonography regarding invasion or vascularity of the lesion, and there is no clear data if elastography would help about differentiation of underlying liver parenchyma. These are images given to me by a company called Bracco, demonstrating the important thing of contrast-enhanced sonography. We do not do that in daily basis. There are many centers in the world that they do not do that in daily practice, since you can use that if you have a focal only one lesion and you want to differentiate that. So the most important thing, like you see here, you have a lesion, it looks different by sonography than the other liver parenchyma. You have a lesion by non-enhanced CT, it is white of high density, but if you inject contrast agent, you see that this lesion, it's not a real lesion. And on MRI, on the upper side, on the T1 weighted image, you see that the lesion is white. So we deal with lesions in segment 4 where less or more fat is present. On CT, the whole liver is changed, and only in segment 4 it's not changed. By MRI, the whole liver is normal, and in segment 4 we have more fat. So the segment 4 is a segment you have to be very careful. What about CT? First of all, that's the technique to see the calcifications, because you don't see them by MRI. You can use multiphasic imaging, so arterial and venous phases. This is the technique to diagnose ACC, and this is the technique to use by oncologic imaging, and this is our course. Our course is oncology. So the American College of Oncology, the American Association of Oncologists, says that the image of choice if you have an oncology patient is CT. There are some limitations because of the irradiation and the contrast allergies. And here you have some examples to demonstrate how important is the CT, even it is done without contrast agent. So you have a mass, a big mass in the left lobe of the liver, and you have very tiny calcifications. If you would do directly MRI after sonography, you will not see those calcifications. Are these calcifications important? Yes, they are. Because if you see calcifications, then the first thing that you deal is the intrahepatic cholangiocarcinoma. Hepatocellular carcinoma might calcify also, but it's not so common. And you have the pathology of this case where you see this kind of dermoplastic reaction. One other thing is the lesions that they have central scar, and we're going to talk about those. Like in this case in MRI, this is a T2 weighted image. T2 means that the water is white, the rule of 3W, white, water, T2. So we have a T2 image, and you have the lesion, and you have the same lesion by CT, and you see on CT you have a little calcification in the center. So although it looks like focal nodular hyperplasia, the lesion is fibrolamellar carcinoma, and fibrolamellar carcinomas demonstrate central calcification. So sometimes CT is superior to MRI because of this help. And like in this case, with colon carcinoma metastasis, you will see in the follow-up CT these tiny calcifications in these men with metastasis from colon carcinoma. And in this case, where we have chondrosarcoma of the ribs, you see those calcifications in the liver that they represent metastatic disease. So CT demonstrate calcifications, MRI is not able to demonstrate calcifications, and CT is the method of choice for the oncologic imaging. What about MRI? MRI is the imaging technique that can characterize the tissue, has a high sensitivity, but low specificity. We can use nowadays hepatodirected contrast agents. We can use diffusion imaging. We can have the all-in-one concept where we have imaging, angiography, and cholangiopancreatography. And this is one of the techniques to diagnose ACC. We have less toxicity of contrast agent than by CT. Now you have by sonography a lesion, looks very aggressive. You have by angio very aggressive lesion. CT is not clear what the lesion is, and MRI with a specific contrast agent demonstrates that this lesion has a massive pooling of contrast agent, which is a typical finding for hemangioma. Two examples of angiography and venography by MRI in order to demonstrate the angiography by MRI, sorry. Nowadays, there's a lot of discussion regarding diffusion imaging, and we are doing in our daily practice diffusion imaging, but nobody is persuaded that diffusion imaging is one of the techniques that could help you differentiate malignancies. So in case of contrast allergies and renal failure, you can proceed with this technique to look at the cellularity of the tissue or integrity of the cellular membranes and potential characterization of lesions, but there is a lot of overlap. True is that you can differentiate from some benign lesions like cysts and hemangiomas, but within the malignant lesions you cannot differentiate by diffusion imaging. Let's proceed to the malignancies. So HCC, hepatocellular carcinoma, is the most common hepatic malignancy. It's related to chronic liver disease, like hepatitis, cirrhosis, or hemochromatosis. We have increase of alpha-fetoprotein. It could come the lesion de novo, like itself, or through a progression of nodules. And the prognosis depends upon the number, the size, and the vascular invasion of the underlying disease of the liver. In pathology, we have three types. We have the expanding one, we have the spreading one, which is more infiltrating, and the multifocal one. We can see necrosis, hemorrhage, or fibrosis. You might have fat and a very specific imaging appearance, nodule within a nodule in this lesion. Calcifications are rare, but very common is the thrombosis of the vena porta. So what about radiology? The most important thing is that sonography is the important tool for screening, and the gastroenterologists do know that. So they will send the patients for screening. It is our job to find the lesion, and the lesion in sonography is of low homogeneity. On CT, we have low attenuation. We don't have a lot of homogeneity in the lesion. So therefore, in the arterial phase, and you have to do arterial phase, if you look for ACC, we have hypervascularity and mixed attenuation. Like I said, in pathology, we have thrombosis of the vena porta, and we have arterioportal shuntings. And on MRI, the lesion is non-specific also. We might have high signal intensity on T2, and we have enhancement. And the most important thing, the companies, the contrast agent companies demonstrate that today, using hepatocellular directed contrast agents, you can proceed to the diagnosis. This is an example to demonstrate the thrombosis of the inferior vena cava. So you have a thrombus by CT or by sonography, and the reason why you have this thrombus is this large lesion in the right lobe of the liver. Now look at the liver parenchyma. You have inhomogeneous enhancement. You have this kind of anomalous surface of the liver. Everything speaks about underlying cirrhosis. So if you have cirrhosis and you have a lesion, the very first thing that you will say is hepatocellular carcinoma. Now what about this case? This is non-enhanced CT. You have the liver, you have the spleen, and you have ascites. And I cover that you don't see the density of the ascites, but the density was very high. So what happens if you give contrast agent? This thing here, it is a clot, a blood clot. And this is the hepatocellular carcinoma that bleeds. So one of the reasons that you might have hemoperitoneum is the reason of hepatocellular carcinoma that bleeds. Sometimes it's very difficult to see hepatocellular carcinoma. You see that you have here in MRI T1, T2, in homogeneous parenchyma. The surface of the liver is very homogeneous with this nodular appearance. But where is now the hepatocellular carcinoma? Those are multiple nodules, and you might suggest that this is the hepatocellular carcinoma, and it was. Now, just to have seen one of those cases, in the past, we used to inject ferrum oxides. So iron in the vein, and this was taken by the reticular endothelial system of the liver. Now this is the T1 weighted image without contrast, and this is the T2 weighted image with this kind of iron injection. The liver will take the iron, and the liver lesion will remain without iron uptake. So that was one of the techniques that were used in the past 10 to 20 years to demonstrate hepatocellular carcinoma. It's now used only in Japan. I wanted to show you a case just to know about that. What happens today is that we have those which are called hepatocellular directed contrast agents. Now you have in T2 weighted image, again, the liquor is white, so this is a T2 weighted image. You have the liver, You have an atrophy of the segment 4. You have irregular surface of the liver. So we deal with cirrhosis. You might be able to see on T2 weighted image this little lesion. On T1 opposed phase is not very easy to see, but using this hepatocytes contrast agent 20 minutes after injection, you see the liver is enhancing and this lesion is not enhancing. So there are some criteria where you can say this is hepatocellular carcinoma. Using diffusion weighted image, now we'll go to another case where you see on the right lobe of the liver a lesion. In fact, you see a second nodule within, and we're going to talk about that, nodule within a nodule. You see that the lesion contains some fat, and on the diffusion weighted image, by high number of P, you have a high signal intensity. On an ADC image, you have low signal intensity. Those are characteristics for a malignant lesion. And if you inject the hepatocellular contrast agent, this is the non-enhanced, this is the arterial phase with hypervascularization, this is the venous phase, this is the what called wash-out phase, and if you have enhancement and wash-out, you are sure that you are dealing with hepatocellular carcinoma. And this is the 20 minutes where it demonstrates hepatocytes activity in the liver and no activity in this lesion. So, for the detection of hepatocellular carcinoma, you need by CT or MRI, and we're going to talk in the workshop about that, at least 2 phases or 3 phases. You need the arterial phase, the so-called late arterial phase, where you have the arteries and the portal vein. You have the hepatic venous phase, where you have filling of the liver veins, and you have the equilibrium phase, which is done like 3 minutes after the contrast administration. And if you have those signs, you don't have to biopsy the lesion to see if it is hepatocellular carcinoma. To make our lives a little bit difficult, there are some variants. So this is the one that they call early ACC, with difficulties in detecting and differentiating that. We're going to talk about the nodule within a nodule. There is a mixed case of hepatocellular and cholangiocellular carcinoma, and the fibrolamellar carcinoma, which is a little bit different than the hepatocellular carcinoma. So we have here a T1 weighted image by means of MRI. We don't see anything very nice on T2. This is the arterial phase, and this is the late phase. So what about those lesions? You don't see them very good. But this patient was operated, and this lesion had hepatocellular carcinoma. So lesions that they are small, less than 2 centimeters, and they look like hepatocellular carcinoma, we call them early ACC. There are some other enhancing lesions, and we're going to talk about that on the workshop. These are not obligatory ACC. And from this publication, you might want to look at that. It demonstrates what is the progression of hepatocellular carcinoma. So we have by cirrhosis regeneration, then we have dysplastic nodules, then we have change of the grades of the dysplastic nodules, so it comes to ACC. So you see the small ACC or the early ACC. Now there is a problem, because not everything that shines is gold. So this is a sonography done by myself, and we injected contrast agent, and you see a tiny lesion. So what is this lesion in this patient that came by a pathologist, because this patient has a known hepatitis C? So hepatitis C, follow up every 4 to 6 months, sonography. These are the guidelines from the gastroenterology. So we did sonography and we found this lesion. Is this lesion ACC? No. And we're going, the late phase, it's gone. And by CT, you see the arterial phase of the same lesion, and the venous phase, the lesion is gone. So if the lesion is very tiny, less than 1 centimeter, and we're going to talk about that in the workshop, then you don't have to say ACC. We're talking about nodule within a nodule. This is a typical appearance of ACC. So if you see a nodule and in the nodule another nodule and you have a cirrhosis, don't dare to say it ACC. This is a variant from ACC and it's very different because it has a better prognosis and it's not related to hepatitis like by ACC. So in this case, you have a central scar which is not a flow scar like in focal nodular hyperplasia. And I have shown this case demonstrating the calcification in the central scar of the lesion. Now, fibrolamellar carcinoma looks like focal nodular hyperplasia. It looks like. But if you look in the center of the lesion by FNH, is a vein. So you see that it's a flow. If you look by fibrolamellar carcinoma, it's not a vein. It's a real scar. So if you want to differentiate a lesion with a scar, you must do MRI. And you must do something that you look at the flow so you can depict it. We're going to talk about that in the workshop. But here you have 4 lesions with central scar, and they are very different. This is hepatocellular carcinoma, this is fibrolamellar carcinoma, this is focal nodular hyperplasia, and this is adenoma. So to have a scar in a lesion doesn't mean that you have an FNH. Let's move to the next. Second common malignancy is the cholangiocarcinoma. This is an adenocarcinoma. Where you are going, if you look at the pathology, you're going to find many definitions about that. The most important thing is that we have the intrahepatic and the extrahepatic, and extrahepatic is referring to the hilum of the liver and to the bile ducts. So this is a lesion with fibrosis that encases but does not thrombose the vena porta. So in the intrahepatic form, the lesion is a mass, and we have seen ones with a little calcification. We might have duct dilatation. And extrahepatic, the lesion is not a mass, but a stenosis. So, intrahepatic cholangiocarcinoma, a mass. Extrahepatic cholangiocarcinoma, not a mass, but a stenosis. So, you have by sonography a mass. It could be everything, but there's no cirrhosis. Could be a solitary metastasis. Yes. If you inject contrast agent, you have some peripheral enhancement that goes from the periphery to the center, like here in the MRI, like here in this coronal image. And the most important thing is that in the intrahepatic case, you don't have changes by ERCP. There are some changes here because of another reason, but for the intrahepatic form, you don't have changes by ERCP. So intrahepatic form, centrally with dilatation of the bile ducts, cholangiocarcinoma. This is the extrahepatic form. We don't have a mass, we have a stenosis, and this is the MRCP. It takes 17 seconds to do that. You have by MRI intrahepatic bile duct dilatation. You don't know why you have the dilatation, but if you do MRCP, then you know extrahepatic cholangiocarcinoma. And this is the coloration with ERCP. ERCP, you have to swallow the whole thing. MRCP, you don't swallow anything. Another example of distally located extrahepatic cholangiocarcinoma by means of MRCP and by means of ERCP. Less common lesion, cystadenocarcinoma. Why I make a brainwash this morning with you? Because every surgeon knows about cystadenocarcinoma. And if you have a cystic lesion in the liver, he will ask you, is that a cystadenocarcinoma? So cystadenocarcinoma and cystadenoma are the same lesions. They are seen in women. It's a lesion that arises from the bile ducts, and you might have a mass and a jaundice. And what is normally is multiloculated, but it could be uniloculated. It looks like a cyst. Here we have a typical case of cystadenocarcinoma. We have a sonography, a lesion with multiple septations. It looks cystic. We have some debris because in this lesion we have thickened bile or blood. On CT it looks very exotic, different densities within the lesion, and on MRI the same, T1, T2, different signal intensities on T2. This is by CT. He has calcifications. Look at the stone, look at the calcification. So if you see a cystic mass with septations in the liver, think about echinococcus, but think about cystadenocarcinoma. If you say the word cystadenoma or cystadenocarcinoma to the surgeon, he will take the patient immediately and operate. So be careful, but be aware of this lesion also. Angiosarcoma, very, very rare. I have seen in my career that I'm old enough, not old enough to retire, but I have seen only 2 cases. So a rare mesenchymal tumor, it's related to thorotrust. I don't know who is taking arsen in our days, but there are other reasons. Actually, it's a very bad tumor with very bad prognosis. He has metastasis and diagnosis, and is the 3rd lesion that could bleed. So the first lesion that could bleed is the adenoma, the second lesion is the hepatocellular carcinoma, and the 3rd lesion is the angiosarcoma. Poor prognosis. And I got only 1 case by CT, non-enhanced CT, very exotic with a big clot. It could be adenoma also, but it is, unfortunately, was angiosarcoma. Something that you might see in your daily practice is the epithelioid hemangioendothelioma. It's a rare mesenchymal tumor. It has better prognosis than angiosarcoma, and it's different than the infantile type of epithelioid hemangioendothelioma. Actually, by this lesion, you have multiple small lesions with a typical bull's eye appearance. So, by sonography, it looks like metastasis. Tiny lesion, looks like bull's eye lesion, but this is not a metastasis. This is hemangioendothelioma. And this is the infantile type where we have cystic lesion. You see that the patient is a young patient, and actually they regress and they don't have bad prognosis. So the last 2-3 minutes, I'm going to talk about this malignancy that everybody knows, but probably you are going to hear some things that you don't know. So liver metastases, everybody have seen those, but you have to be careful about the vascularity of those lesions, and you have to be careful about lesions that they do look like metastases, but they are not metastases. And you have to be very careful about the diffuse steatosis. And you know very good that patients that they receive chemotherapy might develop steatosis, and then you are lost. This is a very nice case. T1, T2, multiple lesions. Okay, patient has adenocarcinoma of the colon. You've got the diagnosis. Look at this case. This is a solitary lesion. T2, T1 without contrast agent, arterial phase, and it is published that metastasis, adenocarcinoma metastasis, they might have a small ring of hyperemia, and this is with this hepatocellular contrast agent where it demonstrates no hepatocellular activity. Difficult, like I said, is if the liver has a diffuse steatosis. So you see here the low density of the liver. There is a lesion. What you see here, and it looks very unusual, is the CT all-in-one. There are some surgeons that they would like to have, because in Japan they do that, CT after injection of bile duct contrast agent. Like in the past they used to do that for the intravenous holocystography. So this is one of those techniques. Look at this case. This is a woman taking chemotherapy. Is anywhere liver metastasis or no? So you have to be careful. And we're going to hear in the workshop that MRI helps on those cases. Sometimes the metastases are hypervascular, and sometimes they produce differential diagnostic problems from intrahepatic cholangitis and abscess formation. Like in this case, we have a pancreatic carcinoma, we have a lesion, it is hypervascular, we have multiple lymph nodes in the hilum, we have compression of the bile ducts, we have intrahepatic dilatation of the bile ducts, but are those lesions that we see in MRI metastases? No, they weren't. Is this lesion metastasis? It's not an obligation that this is a metastasis. It could be an abscess. So be careful if you have dilatation of the intrahepatic bile ducts that you don't miss the metastasis, or that you don't say this patient is dead already. Multiple metastases. No, he's not dead. Because the gastroenterologist says, no, he has only fever. So be careful about that. Just a word about the hypervascular lesions, and this is a neuroendocrine tumor of the pancreas, and these are the metastases. Like the primary tumor, exactly the same metastases. There are some metastases that can bleed also. So, and these are the neuroendocrine metastases, and these are metastases from a carcinoma, where you have high signal intensity in T1, that means bleed, and you have this very nice level fluid appearance because of the hemorrhage of the lesion. This is almost the last slide, and I would like to invite you, if you go home, to look at this site. This is called the response evaluation criteria in solid tumors, and you have to know about that. You must know about that, because the oncologist wants you to know about that. So there are some criteria. You have to measure the longest diameter of a lesion, but you don't always have to pick up the larger lesion to measure. You have to have one that you are very confident about that. You have to have consistency in imaging. You cannot use once sonography, then CT, then MRI. It is important to have IV contrast agent. It is important to scan on a proper time. So there's many things, but look at those. And what I like is RECIST is simple, but to use it is not. So these are examples of inconsistency. CT by PET without contrast agent, CT in arterial phase, MRI in another phase. No, this is a not good technique to do that. Be confident to use the technique that you know, and be confident not to say, if you look at this case, this is a case from my hospital. If you look at this case with non-contrast, you said, oh, a big cyst, that's it. Look at the same case after intravenous contrast administration. The patient has multiple metastases. So I would like to invite you to be careful if you image the liver. You have to know in advance what are you going to do. You have to look at the parenchyma. You have to differentiate if it is solitary lesion or multiple lesion, because metastasis could be solitary too. You have to know about the primary history, and you have to be confident about the modality you use. I'm not saying you use everywhere MRI. No, use CT, but you have to be confident for what you are doing. Think about CT. Think about this day, this morning. Thank you very much for your attention, and we're going to talk in the workshops.